Thank you very much, and thank you very much for having me back after last year. So, thank you very much for the introduction. My name's Dan Monnery. I'm a palliative care consultant, and I lead the palliative and supportive care service at the Clatterbridge Cancer Centre here in Liverpool. I also chair the National Steering Group on Enhanced Supportive Care, which I'm going to talk more about this morning, to try and give a bit of a sense as to what is palliative care, where has it come from, what is it doing, and what are the perhaps misconceptions about it, versus what is supportive care and where has that come from, what are the advantages for people living with treatable but not curable cancer from accessing an enhanced supportive care approach. We're going to talk a little bit around what some of the outcomes are for people who use those services, and then we're going to talk around how it might feel different from a patient perspective to access an enhanced supportive care service compared to maybe a more traditional palliative care service, and then you've got 20 minutes to fire questions at me, so it's a free-for-all. So, starting off then with the World Health Organization definition of palliative care. I'm not going to read it out, but essentially it comes down to the approach of improving quality of life for patients and their families when faced with life-threatening illness, and it covers the management of physical, psychological, social and spiritual needs through prevention and management of adverse effects and treatments. So, is this what you think of when you hear the term palliative care? No. What do you think of when you hear the term palliative care? Death! Yes, you do. And I know you do. And it doesn't matter how many times somebody like me comes and stands in front of people like you and says, it's not about death, it's about quality of life. That message doesn't get through. And the problem with that is that if our aim in palliative care is to improve quality of life and to improve outcomes as well, and the barrier in our name is stopping you from accessing palliative care, then neither of us is getting what we need. We're not doing our job, we're not doing right by you, and you're not getting the support you need to manage symptoms and side effects. So there is a barrier here that we must acknowledge. The other misconception, when I think about it, that's worth mentioning, is a lot of people think that palliative care is to do with religion. Are you familiar with this? No? So, a lot of the hospices are called Saint something. Have you noticed that? In Liverpool area, we've got St Rocco's, St John's, St Luke's, St Kentigern's. There are a lot of saints. And I am mistaken for a priest more often than I care to admit. Even when I have done a ward round, introduced myself as the consultant, physically examined people, and still people have said, wasn't that priest lovely? It's true. And that may also serve as a little bit of a barrier, because we know from the latest national census there are more people who don't identify as religious in this country now compared to people who do. And whilst there is nothing wrong with religion, actually if people want a non-religious medical service, which is what palliative care is, some of the terminology around the hospice names and the way in which we interact with people in a priestly manner might be something that is also a barrier to palliative care. I'm just putting it out there for your consideration. Conversely, supportive care is defined by the Multinational Association for Supportive Care in Cancer as the prevention and management of adverse effects of cancer and its treatment. It includes physical and psychological symptoms, and it's from the point of diagnosis through to post-treatment care. So there's a slight shift in this definition to it being about cancer and treatment side effects and early intervention from the point of diagnosis. Now, the term supportive care, how does that feel to you? Is that a bit more accessible and a bit less threatening than palliative care? Yeah. And I think that was the point, partly, for the shift, actually introducing the idea that we are here to support everybody and not just end-of-life care, and using a different way to describe ourselves starts to break down that barrier between us. But also, The medicine is slightly different as well. So if we look at a trajectory for somebody with treatable but not curable cancer over time, there is a shift in people's needs, and that shift typically goes from treatment-related needs to cancer-related needs, by which I mean, if you are having treatment and you're managing your cancer more as a chronic disease, then your needs might be more around treatment-related side effects, chemotherapy-related, nausea and vomiting, neuropathy. You might have radiation side effects that need managing. But a lot of the needs that you might have will be around preserving normality, staying in work, carrying on normal family life, accessing financial support, so that you can live normally with a chronic illness. The psychological needs, again, are there, because the psychology of living with a chronic illness is actually very different to the psychology and the psychological needs of somebody who's approaching the end of life, but they need to be catered for. So the needs shift from that to the cancer-related needs as the treatments become less effective and the cancer becomes more burdensome. We're then into the territory of managing more cancer-related symptoms and side effects, some of the more psycho-spiritual support around end-of-life care, some of the practical arrangements around setting up hospice referrals, care in the community, additional equipment, and all of the practical arrangements that go with that and the support that you need. Now, my argument is that palliative care in its traditional sense was set up to do the stuff in blue, to pick up the people as their cancer becomes more of a dominant problem and manage that, whereas supportive care is aiming to do the whole lot. And the importance of that is, if your needs are changing over time, the last thing you want to do is to have to change your team. If you know your team and you know that they've helped you through treatment and you've got that rapport, why would you want to then shift to a different team as your needs are changing because the treatments are becoming overtaken by cancer-related side effects? So that's what supportive care is aiming to do by taking a broader approach but an earlier intervention. Now, enhanced supportive care is a model that I'm particularly interested in because I'm the chair of this particular work stream, and it's a model for implementing multidisciplinary early care for people with treatable but not curable cancer. And this is the picture that springs to mind whenever I talk about it, and what we're looking at here is a contrast between usual care on the left and an enhanced supportive care model on the right. So on the left, you've got the patient goes to see their oncologist. I wonder if my laser works. Aha, there we are. So, patient goes to see the oncologist, gets their treatment plan and their information, and they can be referred to any number of supportive care specialties. So they've got physiotherapy, occupational therapy, dietitians, psychologists, all of those things exist. But they work in silos. They don't necessarily communicate or coordinate with one another. And if the patient's needs change over time so that the supportive care they've got doesn't quite fit the need, they've got to go back to the oncologist and have a new assessment and a whole new set of referrals. And if they're not seeing the oncologist at that time, or if they've completed their treatment and aren't seeing the oncologist again for whatever reason, their access to the wider supportive care system disintegrates. If we contrast that with the image on the right, patient goes to the oncologist, gets their treatment plan and their information, and they're referred to a coordinated supportive care team with a coordinator in the middle. Now, often in enhanced supportive care services, this is a supportive and palliative care team, and that team's role is to do that holistic assessment of needs and be that person's single point of access. And they have access to all of the supportive care services that we had before, the physio, OT, dietitians, psychologists, palliative care, everybody. But the way they organise it is based on your holistic assessment, giving you the people you need at that time, and then changing it as your needs develop or alter over time. And you keep having that single point of access that you communicate with, so that if you're not seeing the oncologist for a period, it doesn't matter. Your supportive care is still running alongside. And the idea behind it is that it is distinct from, but in complement to, your oncology care. So where's this come from? Well, the reason for the development of things like this, like ESC, is the recognition that people are living longer with treatable but not curable cancer. Survival for these kinds of cancers has increased sixfold in the last 40 years, but with distinct needs, new treatments bringing about new toxicities that people haven't had to manage before, the psychological needs of living with a chronic, incurable condition. Again, that's very distinct, and that's not catered for in the traditional palliative care psychological support model. And we know from the research that this group of people who have incurable cancer but are not at the end of life have the highest level of need that can lead to the greatest number of appointments, the greatest number of hospital admissions, the greatest number of A&E visits, and the longest length of stay if you don't do something to support people in a bespoke way that suits their needs. So this is where we're targeting our enhanced supportive care services. Now, enhanced supportive care was launched by a national sequin in 2016. It's still growing. It's up to about 25 cancer centres in England at the moment, and other services around the country that don't call themselves enhanced supportive care but do the same kind of thing. And alongside that, there's increasing recognition from lots of professionals about the role of early supportive care alongside treatment in treatable but not curable cancer. But we've taken the liberty of studying this a little bit to see what does this actually do in terms of benefits for patients. So we published a paper in 2023 looking at 8 ESC services across England, and we looked over a year how many patients accessed those services, what kinds of needs they had, what were the outcomes, and we put a 6-month follow-up on the end as well, so there was 18 months worth of data for that one. And what we found was that across those 8 centres in a year, 4,500 people accessed their ESC services. And across all of the primary tumour groups involved, there was a reduction in symptom burden by people accessing ESC. So that's the main thing, and that's what you want it to do. You want it to improve quality of life and reduce symptoms. But what we also noticed is that by doing that, people didn't need hospital services as much. So there was a massive reduction in the number of hospital admissions and length of stay and A&E use, to the point where actually it was extremely cost-saving. It cost £1.6 million to deliver that care for a year over those 8 centres, and it saved £8.4 million in unused admissions to their local hospitals compared to the regional averages. So it's a very affordable model of care to be proactive and support people on a proactive basis rather than waiting for people to hit crisis and end up in hospital. And that's the point we're making at the moment with things like the 10-year cancer plan. Of course, that's coming out in the autumn, going to be telling us what the direction is and what we should all be aiming to provide in terms of cancer care. We want this to be part of that. We also noticed that of those 4,500 people, a proportion of those people did die within the follow-up period, but we noticed as well that those people were more likely to die in their place of their choosing, either home or a hospice or a hospital, whatever they chose, compared to their regional average. So this comes back to that idea of continuity. If you're seeing somebody early and you keep with that same team throughout, then actually that improves end-of-life outcomes as well as the survivorship needs that people have alongside treatment without you needing to chop and change your team. So, I'm going to check the time. Yeah, cool. So, how might this look different then, from your perspective, if you're going to see a clinician in an enhanced supportive care service compared to a palliative care service? And the example that I tend to think of that exemplifies the biggest difference is chemotherapy-induced peripheral neuropathy. Who's got chemo-induced neuropathy? Ah, you are my people. Anybody been to see their palliative care doctor for their neuropathy? 3, yeah, 4, 5, the minority. Because why would you go to the death-mongering priest? Well, I'll tell you. So if we think about this from an enhanced supportive care model, where actually what we're aiming to do is to do that holistic assessment and involve the right teams, let's look at it from a chemo-induced peripheral neuropathy perspective. And I run a clinic that does this, so I can give you the example of how it works. So people with chemo-induced neuropathy will come to me and we'll have a holistic assessment. What's the symptom like? How does it affect you? How does it affect your life? Can you walk? Can you work? What is the bigger implication of your neuropathy? What have you tried so far in terms of medications? How active are you? That whole aspect of what makes you you and how does this impact you. Then we do some medical stuff because I'm a doctor, so that's what we do. So looking at Bloods. So have we checked vitamin B12, folate, iron levels, thyroid, diabetes check? Because we can sit here and say it's chemotherapy-induced neuropathy, and most of the time we're right, but we're not right all the time. And if we don't bother to check for the other stuff, we can't treat it. So that's part of the process. Then we're looking at our evidence-based medications. Those of you with neuropathy, did you know that duloxetine is the most evidence-based medication for chemotherapy-induced peripheral neuropathy? No. It is. It's first line in the ASCO guidelines. And venlafaxine's not bad either. Who's taking gabapentin for their neuropathy? Good. So actually, the evidence for gabapentinoids in chemotherapy-induced neuropathy is, there's been trials that show it doesn't work. It's good in diabetic neuropathy, but actually chemotherapy-induced neuropathy is a different kettle of fish. There is more evidence for mint cream than there is for gabapentin. And actually, mint cream's quite good. I will give you mint cream quite happily. And it deals with the burning-y, tingly sensation that people get through the night. You put it on 1% menthol, put it on your hands and feet, socks and gloves over the top, because it's uncomfortably minty if you get it where you don't want it, if you get my drift. And that is a more efficacious treatment, according to the evidence and the guidance, for chemo-induced peripheral neuropathy compared to gabapentin. So we're going to use evidence-based medications. Then we're going to look at what other teams can we involve to support you with your neuropathy. So one of the more effective ways of getting reversibility of neuropathy is exercise. Things that improve blood flow to the extremities are likely to lead to some level of improvement over staying sedentary. Now, so it might be that we need a physiotherapist or an exercise coach to get some activity in a safe way. If your neuropathy has robbed you of your balance, then it's no use for me to say, we'll go for a run. But if we can get mobility looked at by a specialist physiotherapist, then that can start that process of getting more active. Physiotherapists also have desensitization techniques, which can really help pain from neuropathy. So there's a lot more than one reason to see a physiotherapist. And is your mobility affecting your function at home? Do we need an occupational therapist as well in order to see if there's equipment that can make life a little bit easier? And what's the impact of that on your ability to work and finances? Can we solve that, or should we be involving welfare advice to help you access PIP and a blue badge? And we do that as well from the clinic, so linking in those teams. Then thinking about complementary therapies. So the most effective complementary therapies for chemotherapy-induced peripheral neuropathy are acupuncture and reflexology. So where can we access complementary therapies from close to you? There are some NHS centres, there are non-NHS centres in the third sector, but we can refer to them. So it's about signposting to those things that have some evidence of being helpful. And thinking about the psychology of this. You know, it's important that we recognise that this is a side effect of a treatment which can be debilitating. And the number of people that come and see me in clinic and say, I have got these side effects of treatment, I can't walk, I can't work, I can't sleep because of the pain, but the number of people I bump into in the street that tell me I look really well and to stay positive, I take it you recognise that. So, part of the psychological side of this is referring and accessing psychological services, be it professional, third sector, or peer support. There is a lot to be said for finding your people and being able to share your experience with people that know what you're going through without saying things like, oh, don't you look well? And we've got to do that. We've got to know where our local peer support groups are and support you to access them. Otherwise, you're going to start punching people in the street. And I don't blame you. So you can start to see how using this model brings in different teams to help support you with all of the aspects of peripheral neuropathy management. It's not just about picking the right drug, although there is a right drug and a right cream. It's about that wraparound care and doing it early to try and support you along that treatment. It's not end-of-life care. There's no element of that that's end-of-life care, but it doesn't mean it can't be done by a palliative care team or a supportive care team or an enhanced supportive care team. So my advice to you is that if you're offered access to these teams early, you may not need anything from them immediately, but having that link and building that rapport and having that single point of contact is the idea of it for the longer term. So, in summary, supportive care has emerged really to deal with some of the survivorship needs that people have when diagnosed and having treatment for treatable but not curable cancer. It requires early, coordinated, multidisciplinary care. And whilst it contains palliative care, it's not just palliative care, it's that wider team approach. So when people talk to you about palliative care, think of it like this whole team approach, coordinating the different aspects of your care to try and improve your quality of life, as well as being the right people to know already for end-of-life care. If you know them already and they've already helped you through years of survivorship, then they are less frightening if you need them further down the line. I'll leave you with some references in case I've given you some food for thought or reading, and I'll happily take questions.
On that one. As ever, Dan, an amazing talk, and we are lucky to have you in Liverpool. I'm grateful for all the help you provide with my patients. So while you're considering questions, I'm going to take one from online. So a question around Scotland. Scotland. So
okay.
What enhanced supported care services are available in Scotland? The questioner says she feels that, or he feels that stuff has gone back to more end-of-life care. So does ESC exist in Scotland? How do our Scottish patients and ladies access ESC?
So enhanced supportive care, when it was set up, was from an NHS England sequence, so it was not implemented in Scotland as part of the same rollout. But supportive care and the idea of that wraparound care for people alongside treatable but not curable cancer actually existed in Scotland probably before England, I think, and you've got some real champions in Scotland that are leading this, like Professor Barry Laird at Edinburgh, for example. So there are models that are emerging. The problem we've got is there's no standardisation. So whilst I talk about enhanced supportive care in England and we talk around supportive care in Scotland and in Wales, the understanding of what those things are and from a patient's perspective what you should expect to access or receive when you access those services has not been laid out. So what we are doing at the UK Association for Supportive Care in Cancer is, and the ESC steering group that I mentioned before, is to try and set some rules around what does this offer look like. If we were to ask the NHS to commission this everywhere tomorrow, what should it include? So there's two phases to that work. The first is we're doing an international literature review, scoping review, looking at what models are shown to work in the way that we design these. And then there's going to be a national census exercise going out to all the organisations that provide cancer care in the country, plus patient groups like yourselves, saying, of these evidence-based options, what do you think should be core, and is there anything missing, and how do we then turn that into a service specification so that if the cancer plan turns around and says, yes, supportive care or enhanced supportive care or supportive oncology or whatever they choose to call it, yes, this needs to be a commissioned core part of cancer services, we can hand them the service spec and say, right, that's what you've got to pay for then. But at the moment, there isn't the standardisation. You've just got the interested people at the moment.
Any questions from the audience? The lady at the back, I think.
So at the moment, the area that I live in isn't on your map, and we're at a level at our hospital trust where to get a scan is sort of almost a bonus and something you're thankful for. When you go and see the secondary breast cancer nurse, I mean, I've been to see about neuropathy, and she said there is a drug, but it will make you feel tired, diarrhea, all these other things, so you don't want to go there, and that's it. Okay. When you're at that level, how do we sort of educate the secondary breast cancer nurse, and what do you think we can do in our position if we are in an area like that?
So I won't ask you where you are, particularly. But I think the fact that you're coming to something like this and you've heard about these treatments and the impact of them and the evidence base behind them gives you a bit more clout to be able to say, no, I know that duloxetine is first line in the ASCO guidelines for chemotherapy-induced neuropathy, so I would like to give it a go. And if your breast cancer nurse doesn't feel comfortable to prescribe that, then maybe asking for a palliative care referral to somebody who is comfortable to prescribe medication like that. I think whilst we're in a situation where there isn't very much standardisation, unfortunately, it falls upon you to advocate for yourselves more than I would want you to, but this is the world we're in at the moment. So being able to say, no, I want to see palliative care and I need this symptom controlling. And it may well be that duloxetine, has side effects and gives you diarrhea. It can do. It's the minority rather than the majority, but it's certainly a possibility. But we won't know till we try.
And that goes for most of the drugs we use in our clinic.
Well, exactly. Pick me a drug without side effects. So I think it's having the confidence to say, this is the education I've received, this is what I would like, and if not, can I have a referral to palliative care? But also, I suppose there is perhaps a role for that person to get their own education. So if you're saying to them, actually, there are guidelines around this that we've heard about, that might stimulate them to go on courses or go to conferences and hear a little bit more about these things. Because we are out here talking, giving people education on this. So it's difficult to advise you more than advocate for yourself, I'm afraid. We're trying to do what we can to produce some standardisation from a national footprint, but we're not there yet.
So I'm going to take two questions online. They're very similar. So the first question is, a patient's at a centre that's not an enhanced supportive care unit on the map. So how does he or she get referred? Another question, the patient is at one of the ESC centres. The question is, when should they be referred? Again, how should they be referred? So it's a question of when should somebody with secondary breast cancer be referred to ESC? I think I know what you're going to say, but it's the when. And if you're not at one of those centres, how do you get into one of those centres to be seen?
Okay. So there is difference of opinion on this. And again, it comes down to the fact that we haven't standardised it yet. So my view is that you should be referred at the point of diagnosis so that you've formed a link and then you can dip in and out of that service as and when you need. So if you're at the Liverpool bit of the map, I'll see you in clinic in the next few weeks. So early, I think, is important. And a lot of the research that we've done and published on ESC does say early is the important thing. But there are some models where it's more reactive. I don't know, that's perhaps unkind of me to say reactive, but if we look at, for example, the Christie model is you don't see everybody all the time. You have access to the enhanced supportive care service and you get given a number that says, if you have needs around symptoms and side effects, you call this number on the Monday and you'll be seen in the week at the Christie by all of the professionals that you need. So the way in which it exists at each of those centres actually is very different. And the reason for that is when NHS England set the sequin up, they let each centre design it around what suited them best in terms of resource and the needs of their patients locally. So in fact, there is no uniformity between how they look. So if you compared the Cornwall model is a community-based model. You get referred to enhanced supportive care and they support you at home rather than you having to go to Truro. So it looks a bit different everywhere. If you want to get access to your enhanced supportive care service, I think one of the fail-safe ways is to ask your clinical nurse specialist or your consultant for a referral. I think they will always have access. Some centres, again the Liverpool one, you can refer yourselves. And when we come up with the national service specification, it will be clearer as to what each service needs to adopt in terms of the referral pathways. But again, that's variable at the moment as well.
Any questions? I mean, the other point to make, if you think you're facing a brick wall for whatever reason, anywhere in your sort of cancer journey, is PALS is very good, Patient Advisory Liaison Service. So if you ever feel that you're not getting anywhere, you're not being listened to, you're having problems advocating for yourself, phone PALS. PALS is there to help patients, advocate for patients. They're also there to prevent complaints. What hospitals don't like is complaints. They cost a lot of time and money. PALS is there to sort of prevent those and help you. So PALS is a very good place to go if you feel you're not being listened to or, something's not quite right. Lady in the stripy top.
I am in apparently an area that has a centre, and I have connective tissue disorder, which all the treatments seem to be making worse. And at this stage, I don't really know. I do know some bit is neuropathy, but the other bits I'm like, oh, is that neuropathy as well? But basically, everything is sent back to the GP. So I'm currently on a 53-week waiting list for physio. So I'm thinking from my GP, I think it's 50, about 8 months. Is that 50? Well, anyways. And I'm thinking this is just ridiculous. So listening to you, it's like, not wanting to talk about the analogy with the priest again, but it feels a bit like you're preaching to the converted. It's like we would love all this holistic, I would see it, support. So I'm thinking, should I go back and say, I don't want to go via my GP and via physio. There must be another route.
I wouldn't be waiting 8 months for physio if I were you. I would be saying, actually, I want the
I'm going to quote you in my...
Yeah, do. Make me lots of friends, why don't you? So, no, but I wouldn't. I think if there's a supportive care service, there are physiotherapists within cancer centres, for a start, and some of those are integrated with enhanced supportive care services. And if you've got an enhanced supportive care service in your area... There we are. So if those are your needs, then you should expect to be referred. Now, it might be that the supportive care service says, actually, we don't do our physio in-house, we link you in with the palliative care physio in the community, but that's still not an 8-month wait. So, So I think you're in the wrong bit. So I would say to them, no, this is the referral that I want. And I know this sounds a lot of me saying you need to go out and advocate for yourselves. It's not what I want to be saying. I'm hoping next year I'll be able to give some news as to progress on standardisation. But at the moment, it's about you knowing what is available in your local area so you can say, no, I've got this and this is what I want. One of the people that was here last year, who was from the Northeast, went back to their Cancer Alliance after I said, advocate for yourself, got a seat on the Cancer Alliance board as the patient representative, and has now got them by the scruff of the neck until they commission an enhanced supportive care service. Not that I want to give you ideas.
So Dan, on that very important point, so many of the ladies in this audience have highlighted they're on that map, they know nothing about ESC. So how do we empower and give knowledge to the patients that you spent a lot of time developing these services, that these services are valuable, that they reduce pain, distress, psychological morbidity, cost the NHS less money. So how do we get the message out to the ladies and the men with secondary breast cancer that they exist, and to ask for them, and where they don't exist, and ask them to create a few waves to get them? Because it sounds like they're all there, but the patients don't have that knowledge and information. It sounds like there's an information gap in around that. So how do we bridge that? How do we get the information out so people can advocate for those services that clearly they need?
I mean, I don't know. I think today is a prime example of one of the ways in which we go out and educate, and that's why it's a pleasure to be invited to come and talk to you about these services, because you are exactly the people that they were designed to support. In terms of the cancer alliances, they know about these services because all of this modelling and the proposals around supportive care have been disseminated from the National Living With and Beyond Cancer Board at NHS England down directly to the cancer alliances to get them to consider personalised supportive care on each of their patches. So they have all been given enough information to be able to say this is something that people want. Where it's at the moment is because of the shifting sands of what is coming in the cancer plan, what have people got money for, and all the rest of it. Nothing has particularly happened. But if you go to your local cancer alliance and say, I want to have a conversation around what supportive care is available to me, it will tie in with what they've been told and information they've been given nationally. They don't not know about these services, particularly the ones on their own patch. So I think in terms of what you can do, the people I would speak to are your Cancer Alliance, because they're the ones that have directly been given the information, and they are also the ones that have a bit of sway over the cancer centres to be able to say, we're getting questions about where this supportive care is going to come from, where is it going to come from, and the cancer centre can come back with an answer. In terms of education, that's a bit more tricky, because how do you reach everybody? I don't know the answer to that. I would be grateful for some answers if you have them, but actually other than coming to patient-facing summits such as this, it's difficult to reach people.
But the charities may have a role, so sort of, yeah. Advocate. Yeah, exactly. Because I think the charities are very important. Yeah. So we've got some questions over there. So we got, I think, 3 questions. Is that correct? So, and then Donna at the back, and then the lady in red. So we're going to the left side of the room.
What, me? Sorry. I think mine would be quite quick answer. Is the ESC a push towards, more parts of the country having a proper ESC plan? Is that going to be part of the Labour Party's National Cancer Plan, do you know?
I don't know.
They aware
I want
of
it to be. I have jumped up and down, and I want it to be. We don't get any visibility of what is going into that plan. We know what the overall aims are in terms of improving outcomes, improving survival, improving the use of digital technology, and improving patient experience with living with and beyond cancer. And so we have positioned ourselves as a service model that achieves a lot of that, whilst being very cost effective based on that research that I've shown you. And I'm hoping that the Labour Party will have a look at the health economics of it and say, actually, that saves some money and is good for people, so we want to do that. So we have submitted it to them, but we don't get anything back until it's published.
And we've got hope because Ashley Dalton was here yesterday, and Ashley's living a second breast cancer. She made it very clear that when she took over that bit of her ministerial portfolio, that she changed it to not only about, trying to cure cancer, but also living with cancer and living better years with cancer. So I'm hopeful, given that we have a minister living with an incurable but treatable cancer, that is centre stage in that cancer plan. So I find that very reassuring. Lady in red.
Mine's not really a question, more of a support. When I was first diagnosed with secondary, I was referred straight to my local hospice, who have been phenomenal. They give me an hour's appointment, I can sit, I can talk to them, I get all my pain relief from them and anything I need from them. So I don't really have to access my GP, which I know is even more difficult to access. But the word hospice scares some women to death.
Doesn't it? Yeah.
They are, like, hospice, I'm not going there, that's where you go to die. You don't go for your treatment. But they have been, from my point of view, they have been fantastic. And I would recommend anybody to try and, look at their local hospice rather than going to their GP.
Yeah, I agree. I think, and it sounds like that, again, they've not called it enhanced supportive care, but you've got that team around you and they troubleshoot a lot of different issues. It's exactly what we're trying to do. Of course, people are frightened by the word hospice, so that's why we've set these things up in cancer centres, really, to try and catch people and link them in. And part of what we link people in with is their local hospice. If you've got something that take, for example, the complementary therapies approach, I haven't got that, but my local hospices do. So actually that might be the link we make with the hospice so that you're in that service as well. And it's less frightening, I think, you'll tell me, if you know you're going there for something specific. So if you're going for a particular treatment that is available in that building, actually the term hospice is a little bit less frightening because you know they're there to do a job, that you've had a conversation with somebody like me beforehand and you know what you're going in for. In the future, I wonder if enhanced supportive care, or whatever it turns out to be called in the long run, I wonder if it might be delivered mostly in the community and mostly around hospice services, because they have got these teams there that could do that wraparound care. And actually, isn't it better to have this multi-professional supportive care closer to home than having to go to a tertiary cancer centre? That's my thought. Now, I don't know if that's what's going to come out of the 10-year cancer plan, but we do know that there is an emphasis on shifting from hospital to community. So I think if this was going to appear nationally standardised and commissioned, I do wonder if it will be a community and hospice-based service. And I don't think that's a bad thing, as long as we can get over that barrier of the name. And the funding. Oh, I would expect it to, if it was in the cancer plan, I would expect it to be funded.
So Donna's got a question, and then I'll take a question online, and then I think we'll have one in the audience.
Thank you, sorry. Going back to patients being their own advocates, I think that's quite sad. I think they've got enough to be dealing with as a nurse. I think that should fall on us. So I think us nurses and professionals, from Cancer Alliance down, we need to be aware of, what's out there and how to refer. And I do agree that patients should be referred at the point of diagnosis because they don't know what they don't know. They don't know that this is peripheral neuropathy and what we can do about it, and access and things. And I think at the point of diagnosis is when they're at the peak of quality. and we need to keep them at that. And again, as you say, building relationships. So I think there should be some sort of prescriptive thing that, you know, as MDTs, as a specialist MDT, this is a patient who's now being diagnosed secondary, we need to refer on, and that way we can also capture numbers, which we're sadly lacking as well.
Absolutely.
But I think, you know, patient power is important. We've got patient reps on our Cancer Alliance. I think we're very lucky in Liverpool to have such an engaging, enthusiastic, caring, approachable, accessible team. And I think it's sad that that isn't the same up and down the country. And I think invite whoever that nurse was who doesn't know what to do, invite her to the next meeting.
So I'm going to take 2 quick questions online. So they're around GPs. The first question is, I'm going to do it in 2 parts. How does GP fit in with enhanced supportive care? The second bit is that a lady, or gentleman, because I haven't got any sexes here, I say lady and gentleman because we also have some men with secondary breast cancer, had acupuncture for her neuropathy, it worked. So the question is, how can that be fitted into hospitals accessing some alternative therapies that may be useful for either chemotherapy or cancer-related side effects? So the role of GP and ESC in accessing acupuncture in sort of hospitals.
Okay, so there is no reason why your GP can't be that central coordinating point in that globular model I showed you. Remember the picture with the left side and the right side? Your GP could do that, but the medical bit of that requires some expertise in symptom control, so it would need to be a GP with a special interest or with additional training, I would have thought, and that is the model at Chelsea and Westminster. So theirs is run by a GP with special interest. So that can happen, but it's about having GPs that want to do that rather than putting the burden of this coordination onto already stretched primary care services. I think this is something above and beyond what we would expect primary care resource in its current form to do, but I don't think that we would expect them to do that as a whole. I think we would look for interested GPs that want to do that for this particular reason. The other question... Acupuncture. So yeah, acupuncture is great and it's evidence-based, but it's not something that is commissioned across the NHS. Again, there's no standardisation to it. So I think it's about knowing where you can access it in the local area. So when I see patients who would benefit from acupuncture, I can't offer it on the NHS. I haven't got that. But there are services based in the Lyndon McCartney Centre in the Royal that do it, the Wirral Holistic Centre over at Wirral. So it's knowing where your third sector organisations are that offer complementary therapies and signposting and referring in your local area. A lot of this currently depends on a close working relationship between NHS and third sector.
Okay. So can you all join me in thanking Father Monnery for blessing us with his knowledge?